Hello. Hi, how are you? Mhm. Hi, Kathy. How are you?
I'm good. I'm very good.
Good. Good to see you.
Yeah. How's your day going?
It's going pretty good so far.
Yeah. Did we get any more registered participants?
No. Well, we one or two more. So I think Jennifer's working on sending around a final email now.
Oh, good.
But
Okay.
yeah, we'll record the webinar and then we'll continue to promote it afterwards. What we're hearing from our board is that this was just a particularly busy day for, a lot of people who normally follow what's going on with the map. There's a kind of a bunch of additional people. Hang on, I just got an email. Uh, hang- okay. Yeah, so we'll continue to promote the webinar even after. So we'll promote the recording.
Okay. Yeah. I know a lot of the like school nurses and teachers and principals, um, it's in the middle of the day, so it
Right.
made it a little difficult. So yeah.
Yeah, that'll do it. Hey, Jennifer, did that make sense?
I didn't see a response. Let me see.
Yeah. I didn't set the webinar up to do a reminder, so I think maybe an email just to the general list, alerting everyone that the webinar is about to start.
From
People,
MailChimp.
yeah, people should be able to register and attend even after the webinar starts.
Can you send me, do you have a link, like the Zoom link, and I can just embed it?
It's the same link that is in the original that was in the original registration email. So you can just
Okay.
send that same registration email out with a different subject line.
Yep. Okay. I'll do that real quick.
Okay. So Kathy, I saw the video, and that looks great. Is that a video that you want to play, or do you want me to play it when the time comes?
If you could play it when the time comes,
Okay.
I would know how to attach it
Right.
on
Yes.
this.
That sounds good. So I'll do that. So just let us know when you're ready to play the video, and
Okay.
we'll make that go.
Okay. So as far as the format goes, is it something that you introduce and then Dr. Perfect talks, Gatto maybe talks, or how do you see the progress going?
Yes. So Jennifer will be the master of ceremonies for the webinar. So she'll introduce the webinar and introduce each of the speakers. So she will first introduce Dr. Perfect and Carolyn Tarad, and then they will present, and then Jennifer will introduce you, and then you will present, and then Jennifer will moderate questions, Q&A. So, are there any questions that you would like us to make sure that get put to you?
Now, I sent the list, the notes, and then I went through ChatGPT and kind of refined it a little bit better for myself. But I think that if there's something that I sent and you said, gosh, that's a great point, she's not bringing it up, then it's a great way to say, there's a question here, Kathy, or, there's another thought that we discussed at one time, and then just kind of put that card on the table to cue me to say, hey, oh yeah, I did talk about that, or I did mention that in my notes. So, because then the conversation's going back and forth versus us just, you know, talking, because I can talk forever. But so that's one thing that I thought. And I think maybe after the introduction of myself, that 4-minute video might kind of, because we've had two presenters speaking, we've had Dr. Perfect, we have had Gatto, and then if we have a moment where we do something a little different that versus hearing another speaker,
Okay.
that might help, to kind of look at the momentum and engage people.
Okay. So after Jennifer introduces you, then we'll play the video, and then you'll
What I
take
think.
over. And you should plan on talking for about 15 to 20 minutes.
Okay.
George, you guys can see my slides?
Yes.
And I think Dr. Perfect and Gatto will chime in at any point, say, okay, Kathy, go do that again, or tell that story one more time, or explain this a little bit better, or something. That way
Okay.
it's,
Yeah,
yeah.
great. Jennifer, I got the email, so that looks great.
Great, perfect. Caro, is it Caro?
Yes.
Here, and can you pronounce your last name just so I make sure I get it correct?
Yes, two-row.
Churro, okay.
Yep, just like two ROW.
Yep, got it. Perfect, thank you.
And then I did send the corrected version of our presentation.
I saw that email. I think, can you share your slides real quick, both of you, just to make sure we can see them?
Yep, I'll just go ahead and, oh, I needed to send a request.
Yeah, I didn't create any slides.
You have no slides. Okay, but you just your
Photo.
video. Yeah, we're going to play your video. Sorry, I was doing something while you guys were chatting. We're going to play your video in between Caro and Michelle's presentation. And then after they're done, I'll introduce you. We'll play your video and then you'll jump in after the video.
Yes.
Okay, perfect. Great. We can see your slides, Caro. And Michelle, perfect. Is that how she pronounces?
Mm-hmm.
Okay, great. And I think I've got you, Kathy Flores Bell.
Yep.
Good.
Hey, Dr. Perfect. There you go.
How are you doing?
I'm doing well. It's so good to see you.
Yeah, it is good. I'm glad you were able to do this. I put your name out there and I was like, I would love to have a presentation with you.
Oh, how funny. God.
Yeah.
Oh, this is good. I was telling George and Jennifer that this really brought up a lot of, I don't want to use the word trauma, but going back and
I'm
remembering
sorry.
things. Oh my gosh. I was telling my husband last night this, I just remember how hard it was. And then I did a kind of a look-see on, when you're living through the changes of something like this for a medically fragile kid, and you don't realize that as the family, you guys are pioneering something. So every time you pioneer something, there's going to be all the perks and whatever, but there's also the casualties because people get
Absolutely.
left behind. And or they don't know that this is something that's still in the works. And so I
Mhm.
think that's a great piece of information to remind leaders and policymakers and, just everybody that we didn't
Yeah.
realize. We didn't realize that hospital schools were really, and we heard all about Dr. Perfect and all her research, and we just thought it was all all in place.
Yeah, no, and I feel like since we met, there's actually been repeals on these laws that Caro and I discovered instead of advancements. A couple states have. Caro, in the one that I saw attached, I still didn't see two of the slides didn't come through, so I don't know. I'm assuming they're here. We should make sure that they're visible here. The ones that are relate to the two slides of summary of the statutes. Like when I
Um,
download it on it just has like an image for results for aim one.
is it okay if I share my screen really quick to
Oh yeah,
confirm?
I'll stop share.
These two?
Yeah, they look fine there. I don't know why. I don't know if Jennifer, the ones that you have to distribute are have the same issue I had because it's even the right email because you said sorry I gave the wrong ones and then I downloaded that. So let me try again. I don't know what's going on.
Yeah, if you we won't post it right away. It will take some time to get the video uploaded and
Okay.
set over to the map website so we can make sure we have the correct slides
Yeah.
after the presentation. And I'll turn them into
Yeah,
a
it's the
PDF.
same. It's the same issue. I don't know.
Oh,
Anyway,
if I convert it to a PDF, you wouldn't have any issue. I think
Yep.
it's because it's converting to a PowerPoint. So let me go ahead and do that now.
Yeah, I mean, no rush. You can do it afterwards if you like, but just convert it to a PDF and we'll post the PDF. And Kathy, are you okay with us posting the video?
Oh, sure.
Okay, great.
and if you need to, not as a therapist, but if you need to debrief after Kathy, that to have that emotional moment, or like we can touch base.
Okay. That's funny. Yes. Never know.
Because I think I've always seen you more in an action mode, and you probably, when you get in that mode, you're able to intellectualize. Like that's how I'm able to do that with a lot of the work I do because of the, people I work with.
Rare, serious medical condition.
Oh my goodness, wow.
Are you able to hear the video, Jennifer?
The red cell.
Yeah, it's pretty quiet, but I can hear it.
Does
Okay.
not produce any red cells or the cells.
So George, you're going to start the video?
Yes.
Okay. Oh, and then Michelle, Carl, I'm not sure you heard the discussion between Kathy and George. So what we'll do is I'll do a brief intro at the beginning. Then I'll highlight each of you. I won't go through your bios at that time, but I'll just mention that we have wonderful guest speakers joining us today, and that I will introduce them more fully before their presentations. And then after I'm done, I will introduce you, Michelle and Carl, at the same time. I'll read your bios, and then I'll hand it off to you. And then when you guys are done, I will thank you, welcome Kathy. I'll read her bio, and then George will play the video, and then Kathy will do her presentation, and then at the end, we'll do all the Q&As.
Sounds great.
Yeah, we're really excited you guys could join us. I'm excited for this. And, we talked to our board yesterday. There's a lot of conflicting meetings happening today, so I think we're a little light on registration than we would normally be, but we publish it on the MAP website. Our partners will promote it through their newsletters, and we tend to get a lot of views once it's published on the MAP website as well. And then we encourage you, we'll send you the link. We'll send the link to everyone who registered and encourage them to share it as well.
That sounds great. Thank you so much.
Good.
Good. Do you have any questions about how the webinar will run for us? Okay, good. Good.
And Valerie's joining us. She works here in the center. She's kind of back up in case something happens to George and I, any of us fall off. She'll be there as an extra to help.
Yeah. Oh, that's a good point. So if for some reason you lose connectivity during the webinar, just log back on and we'll keep the webinar going. And then we'll pick you back up wherever you left off. So Don't worry about that. Okay, the last 5 minutes are always the most stressful part of any webinar. Five
I
minutes
know.
before it starts.
And I haven't done this format before, so I hope and it's different. I don't know. I mean, I've done webinars, but not in, I don't know why I feel like it's different anyway.
Yeah, yeah. Each experience is its own thing, that's for sure. But this will be good. Yeah, we're looking forward to it.
And I think Caro's dissertation is getting more of that humanizing side, and both I was interested in what the educators' experiences are and how they're faring, and now she's getting some family experiences. So
I'll bet. Gotta, and then talking to the other hospital school teachers or, leaders or whatever, that's gotta be huge.
Yeah, it's been
Fascinating.
Yeah, the teachers have been so, willing to participate, and now getting some traction with families has been, getting to just see the real world experience, because we've seen a lot of the, the numbers and the policies, and to see like what it's like actually providing and receiving the service. And there's just so much still that needs to be improved, and I'm just really excited to, just share awareness about this because a lot of people just didn't know that this is out there. And
Yeah.
And I think the one thing we did notice was that there was a lot of momentum I have from the initial news stories to the startup. I mean, there wouldn't have even been a position if we didn't ask the local place if they have a hospital school teacher, and they didn't even know in Phoenix their banner had teachers already. But when administration changes and policy, and you have to start all over, and the pandemic really disrupted the continuity. And right now, there's someone in there who doesn't support that partnership in our banner. And so, but like we're hearing about other places where they're like a teacher starting it up. And they were a parent and they're also a teacher and they're starting a program up. But some of the government stuff are shutting down some of these. The funding that was going to other things and that was trickling down to hospital school programs. They're cutting staffing because it doesn't make money. So that's more anecdotal, and that's what Bacaro is finding out. So we'll see.
I'm going to share my screen now, I think.
Okay.
And oh, so just one last thing. I think if you're not presenting, just turn your video and audio off, and then I'll ask you, if you forget, I'll ask you to turn it on during your presentation or remind you to turn it off. But we typically just have those turned off, the audio and the video during each other's presentations. All right, George, what do you think? We got 2 minutes.
Yeah, I've got 11:57.
Oh, yeah, I know. My computer's always running a minute behind. My computer is a minute behind my phone,
Right.
but I don't know why it always is.
I'm going to test the background music, Jennifer, so let me know if you can hear it.
I did, and then it went away.
That's what I heard as well.
I still hear nothing.
Yeah, let's try that. How about now?
It started and went away again.
I don't know when it's doing that.
Well, we can probably just go without without audio and start right at,
Yeah,
well,
let's try this.
yeah, it started again and stopped.
I don't know why the webinars do that, but yep, it's set up to turn all that off. So hopefully we'll get the audio going. So we won't kind of have that normal period where we let the music play while people join.
Okay.
So
I'll just leave my video on, and I think that's fine. And I'll just start. It's 12 now, so I'll just start at 12:01 if you want to merge everyone in.
Okay. All right, I'm gonna turn off my video and my audio, and then I'll start the webinar at 12:01.
Perfect. Good afternoon and welcome to the MAP Talk on learning opportunities for students with chronic health conditions. We're excited to have you here with us today. We also have a great lineup of speakers joining us with Kathy Flores Bell.
Hey, Jennifer.
Yes.
Jennifer, I'm sorry, I haven't started the webinar yet.
Oh, I had 12:01. All right.
I'm going to start it right now.
Good afternoon and welcome to the MAP Talk on learning opportunities for students with chronic health conditions. We're excited to have you joining us today. We have a great lineup of speakers joining us, including Kathy Flores Bell, who is a parent of a child with chronic health conditions and also a community leader in this area. And we have Michelle Perfect and Carolyn Turow joining us, who are at the University of Arizona. I'll do more formal introductions before each of their presentations. Before, I just want to go over a little bit of the logistics for today. All of our MAP talks are recorded. We will post it on the MAP website later this afternoon. It should be up this afternoon or by early tomorrow morning. We will email a link to all of our participants. We encourage you to share the recording if you find today's MAP Talk webinar informative, and if you find that your friends or colleagues or any organization that you're aware of would be interested in this kind of information, we encourage you to share that link. Everyone will be muted except for the presenter, so we will be in conference mode, though we will have time at the end of today's presentation for a Q&A session. So at the bottom of your screen, you can enter your questions, and we will go through them throughout the presentation, and then we'll ask each of our speakers those questions at the end. You can also email George Hammond at any time. He will go through his email and look for any questions that come up or any problems that are occurring during the webinar there. I'd like to thank the MAP Dashboard's partners and sustaining sponsors. It is their contributions in support of the MAP Dashboard that make events like today possible. Our partners include the Community Foundation for Southern Arizona, Pima Association of Governments, the Southern Arizona Leadership Council, the Chamber of Southern Arizona, and the University of Arizona. Our community sponsors or sustaining sponsors include New Point Marketing and Market Research, the Thomas R. Brown Family Foundation, and Tucson Electric Power. They are the reason that we are all here today, and we'd like to give them a big thank you. Also, I wanted to mention that we publish a health-related feature and a business or economic-related feature in the Arizona Daily Star each month. You can look for that business-related feature towards the end of the month in the Sunday paper, and again, that health-related feature towards the end of the month on Mondays on the front page of the health section. So with that, I would like to now welcome our first two guests. We're going to have Michelle and Carolyn do a joint presentation, and then we'll welcome Kathy. So I'm going to stop my share here. And Carolyn and Michelle, you can start your screen. Okay, great. So today, Michelle and Carolyn are going to present on a white paper that we recently published on the MAP Dashboard, and that is the impact of policy on the status of accessible learning opportunities for students with chronic health conditions. This was an excellent paper. We have it published on the MAP website. I encourage you to go and visit it after today's presentation. I'm going to provide the link in the chat below. so that you can go directly to that. But really, it's a great way to learn about more opportunities or the lack of opportunities that exist for students with chronic health conditions. And so Michelle Perfect is a tenured full professor in the school psychology program within the Department of Disability and Psychoeducational Studies at the University of Arizona. She has courtesy appointments in psychology and pediatrics. As a pediatric school psychology researcher and licensed psychologist, her work focuses on sleep, trauma, and youth with chronic medical conditions, particularly diabetes. She investigates strategies for effective collaboration among families, schools, hospitals, social service agencies, and universities to enhance child health and well-being. Her research has been supported by the Institute of Education Sciences, the National Institute of Health, and the National Science Foundation. Dr. Perfect currently serves as past president of American Psychological Association, APA, Division 16, the School of Psychology. She is a former division convention chair and served 6 years as Division 16 VP of Publications and Communications. She has been an active member of APA Committee on Professional Practice Standards since 2023. The current presentation is based on the work done as part of the University School Hospital Alliance for Research on Education Success. And I would like to welcome Carolyn Terrell. She's a fifth-year doctoral student in the APA Accredited School Psychology Program at the University of Arizona. Her research and clinical work focus on children with special health care needs with an emphasis on bridging healthcare and education systems. Caro's dissertation examines the biopsychoeducational model, exploring interdisciplinary collaboration among medical providers, educators, and families. Clinically, she provides evidence-based interventions across outpatient and school settings. Committed to advocacy and consultation, Caro investigates research, clinical practice, and systematic understanding to support children, families, and the professionals who serve them. Welcome. We're really excited to have both of you join us today.
Thank you so much for that amazing introduction, Jennifer. And with that, we'll get started with our presentation. Before me and Dr. Perfect begin, we would like to solidify some key terms to help your understanding throughout this presentation. So some key terms we thought would be useful to know is the definitions of chronic illness, special education, statute, and regulation. A chronic illness is a condition, and various conditions qualify as a chronic illness that one may need ongoing treatment for an illness or disability that has lasted over an extended period of time. Special education is an educational approach that's designed to meet the unique learning needs of children with disabilities, with special healthcare needs, or chronic health conditions that aims to integrate traditional curriculum as much as possible, but also provides those accommodations and individualized education plans when necessary. A statute can be defined as a law or rule made by the government body, whereas a regulation is a little bit different. This looks at binding policy that's developed more by the designated agency. So these are regulations made by the Department of Education. So just a few differences there at the types of policies that we looked at. We want to provide some statistics and prevalence of the population that we looked at and the students that are left behind. So about 20 to 45% of school-aged children receive care for a chronic health condition. So we can see prevalence is pretty high within the United States, with about 8,000 per 100,000 children are hospitalized annually. 13 to 27% of these youth that have that chronic condition, this typically does influence their well-being, and they often experience those short-term flare-ups or even short-term illnesses of their condition that may result in that disruption of school functioning. So we're seeing it within the literature that chronic illness leads to these other kind of barriers within academics that makes it difficult for these individuals to reintegrate into school. They often miss numerous assignments, have academic and learning barriers, social isolation, and psychological stress due to those increased absences. They're more likely to have a learning disability and significant learning barriers, and they have higher rates of grade repetition due to having to miss school so frequently. So what are the services that are currently in place that support, these children and the common academic barriers that they face? We wanted to provide a good visual of how these two services, how they are similar and how they're different. So one of the biggest supports right now is homebound instruction, which this is a type of special education service that's coordinated by the student's school district. This provides instruction that's delivered within the home, within the hospital, and sometimes a non-school setting, so like a library. It focuses really on continuing academic instruction for these students, and in no way is it therapeutic, but it can be perceived as such. Typically, the research is showing that these students receive about 45 minutes per day of homebound instruction once they qualify. So it's really not much. With some states, they have variability on that. Qualification and delivery vary state by state. So every state either has a specific way on how they provide their homebound instruction to their students, and some states don't have really much at all. It's considered the most restrictive educational environment for these students. So it's not encouraged to be placed on homebound. This is meant to be short term and be a supplement, not a replacement. Where on the other end of the continuum, we have hospital school programs. Those are programs that are located in a hospital, and they are meant for children who have prolonged hospitalization and are diagnosed with a chronic illness. This is not legally required by the hospitals, but they decide to provide it because this is a therapeutic intervention that integrates education and health. Majority of the time, we're going to see credentialed teachers within hospital school programs. They're trained to support these specific types of students. They provide flexible instruction that can be either small group, in the classroom, bedside, one-on-one instruction, virtual sometimes, and they really emphasize the re-entry support to the school. So they facilitate special education meetings sometimes, help with 504 accommodations. But what we're also seeing in the literature with these programs is that sometimes access doesn't ensure quality. And the way these two are similar is really they want to prevent academic regression. They focus on continuing education. Instruction really wants to occur outside of the school to keep that normalcy, require coordination between home, hospital, and school, and really just ensures access to education. So really a good brief overview of kind of the supports that we looked at and aimed to provide suggestions for. So policy-wise, what are currently in place most specifically to homebound is what we looked at. Right now, the key federal laws that look at children with disabilities or chronic health conditions, special health care needs, are Section 504, which protects students with disabilities, IDEA, which ensures FAPE, free appropriate public education, and then once they do qualify for special education under an IEP, they typically qualify under other health impairment, which is just one of the special education categories. But overall, what makes this important is there is no universal federal policy as of now that exists for homebound instruction. This creates the availability of homebound for students to vary greatly across states because it's up to the state whether they decide to provide this or not. And then it'll even get more specific as we go district to district. So specifically to Arizona, Arizona does have a homebound law, but it's really unclear of how it fits in the continuum of education accessibility. And that was our aim, to see how Arizona compared to other states in regards to their homebound policy.
Thank you for that overview, Caro. Yes, so we had 3 specific aims for this project that we will go over today. The first one related to the policy and landscape, specific to states. So what we did was we did a systematic review, which means that we first we looked at law websites, an internet search, Department of Education websites, and between January and May of 2024. And during that, we were looking specifically for homebound instruction or chronic illness. And most of them appeared on the Department of Education website, although some were specific statutes and laws. That was established by the legislators. So, and in both cases, they're binding as long as they are regulation or law. And for our coding process, if for the ones that we could not identify, to ensure that we did not miss it or that it wasn't just as less publicly accessible, we also, our team contacted the Departments of Education to make sure that there were not ones that, again, were not available or accessible. Our research team then looked through all of the codes or the state statutes after a 3-hour coding workshop where we were trained to criterion so that 2 people, a double coding process, coded each state policy separate. And then we did a reconciliation. That was to make sure that we were aligned in how we viewed the particular components of the state statutes, and we broke down all of the text to put into a online system, and then we were able to compare that. And the main areas, as you'll see today, were eligibility, instruction, mention of caregiver involvement, how things are managed and coordinated. So on the next slide, we're just going to cut to the chase and see where Arizona is instead of going through and then summarizing. So as you can see on this right side, or my right side, this Ghostbuster sign here, are each of those things inside that circle were identified in at least one other jurisdiction other than Arizona. And that also shows you the different coding areas. So time to determination, Arizona does not have it mentioned. Time to implementation, not there. In terms of definition of intermittent, whether different kinds of healthcare providers, and any of those other things inside that circle. To the other side, in the green circle, those are the 6 areas that were mentioned in Arizona. As you can see, the only certification can be by a MD or DO, physician. They did not have the other healthcare provider option have. And on the next 2 slides, I will show you, even though it's mentioned in Arizona law, where it lands in relation to other ones regarding time to eligible and instructional time. So as you can see here, there's a little timeline, time until eligible. Before I mention that, I wanted to say out of the 51 jurisdictions, which was the 50 states and the District of Columbia, 40 had active policies. So there are 11 states that do not have any state statute or law or regulation related to homebound, meaning there is no binding policy in that state. So even though there are some that are less ideal, and then some that are exemplar, though there are 11 of them who have no guidance or requirements within their state. So in terms of that, 23 states, 45% overall, did have an eligibility criteria for how many days of missed school before that state requires a local school or school district to provide educational services. Here you can see Michigan, Oregon, and Wyoming are 5 days of absence. At most a week, including the 5 school days. And then other states are listed here, sometimes more than once, because they either had wording related to intermittent, which was over time and cumulative, or consecutive days. And so for an example, with Illinois, even though it has 2 to 4 weeks, it's cumulative, and it had after 2 days, consecutive days, then homebound instruction is to be provided. And other states did that as well. And as you can see, where we are in Arizona is 10 plus weeks. We are 90 days of anticipated missed school. It could be intermittent. Again, there's no definition of intermittent. Georgia is there, but as you can see, it also was in the 2 to 4 week range because of the fact that it has a short term eligibility as well as long term. So the longer term requirement is 10 plus weeks, but it is not because they did not enact anything sooner. And so Arizona, we are at 90 days. We are not sure. The law has not been updated in decades. We're not sure how that came about, other than 90 days is typically the definition of a chronic illness. But that means that students can go up to 3 months without instruction if they cannot decide if it happened for anticipated or how intermittent can be defined. And one example for intermittent is a child who might be on kidney dialysis. They're missed 3 days of school, at least half days, if not the full day. And so right there, if they know they're going to be on dialysis for the entire school year, they've already missed that. And according to our law, they would be eligible, but that does not necessarily translate into implementation. On the next slide, you will see a map where we have color coded the number of hours, instructional hours, that the state requires once a child is eligible for homebound. You can see a lot of grayed out. So all those states, 11 of them, again, had no policy to begin with, separate from just this, but the other ones that did have a policy did not note instructional time. The darker colors, or the split colors, are ones that have increased instructional time. There are some that vary by grade, elementary typically lower. And you can see the most common one is 2 to 4 hours or 4 to up to 10 hours of instruction. In Arizona is 4 hours a week once they do become eligible. One exemplar here is New York State, that in July 2023 just updated their time, where it's 10 hours in the elementary and 15 hours of typically individual instruction a week once they become eligible. And again, this instruction can occur either in the hospital, at home. Where that occurs is different across states, but that is the continuum of instructional time. And we think about students being in school, they're typically there 7 times 5, 35 hours. Of course, it's group, and some of these children just can't handle that level, but they don't even have the option if they're not mandated by the schools. And minimum 4 hours does not mean that's the most that a school can give, but most schools will only give the minimum. And then to summarize, and again, you can read the white paper for more specifics, for eligibility regarding healthcare conditions, 47% of the states mention specific conditions. Arizona was a little bit more narrow in just saying a few conditions, but some of them were very specific and was inclusive of mental health. Additionally, educational considerations in that statute was whether the student can profit or would be able to make progress due to that. In terms of eligibility, as we mentioned, a lot of states had nurse practitioners, psychologists. 2 states or 3 states mentioned school psychologists, which were, of particular interest to us in terms of being able to say this child is not able to come to school on a regular basis and that they need provision of service in this alternative environment. And Arizona is only the physicians. In terms of timing, one of the things you think about is a parent, once they find out this is even an option, submits paperwork, and now they are waiting. And 18% of states required 5 to 15 days, but the other states were silent, including Arizona. And in terms of that, the parent can wait. There was one state in terms of Wisconsin that said that they have up to 90 days to make a decision on whether the child is eligible. But other states don't say. So the schools can decide right away or not. And in terms of implementation, once it's decided, I understand the schools often will have to identify who can do the instruction, who's available, set up a schedule. They always are making sure the child's able to do it, but there is very low requirements. There was one for immediate up until 15 days, again, in only about 18% of states. Sometimes these parents are having to renew every 30 to 90 days instead of annually. Although that was the most common, and there was variability in who even sees whether this actually occurs. One example, the student was on an IEP that I have worked with, and they were getting homebound instruction. But one of the issues was that whether they were getting credit for school, which is not necessarily listed in the statutes. And by the time the child was finishing their junior year and they had another individual education plan meeting, they only had 3 high school credits that the parents had no idea, despite all that instruction over time, that the child had only accrued due to passing rate and a number of hours given 3 credits out of 22 required by Arizona. So that's another layer that's not in these statutes. Curriculum requirements. A couple of states, maybe one or two, said let's provide them with the textbooks and supplies. Otherwise, it's not mandated in the law. It might be intuitive, but not mandated. And 10% required a report as to what instructional activities are 12% for instructional activities, 10% to submit progress reports. On the next slide, to give some, again, 18% of states mention when the instructional time can occur, 12% allowed for summer extension, and 2 mentioned weekend or evenings. Other ones, one was said it could not be outside of typical school hours. Now remember, these children are sometimes getting procedures, they're tired, maybe their best time is in the evening. As you can see, two squares down, caregiver involvement. 27% mentioned how they need to be involved. Mostly it's around consent, but 20% of the states required someone over 21 to be present in the location where the service was being provided. And sometimes parents are working. So during the school day may not be conducive to when they can have a provider to the child if there's not someone over 21 who can also be there. Other considerations was the intersection between special education. You do not need to be a child listed as a special disability or just a 504. So, but if you did have a special education, there is a provision and the team is involved. And how it counts for attendance, if a child gets 4 hours in Arizona, for example, they will also get, the school will be counted as having that child full time. So they get their full funding model for that child, but the child only got 4 hours. While it's meant to be flexible in terms of giving the school district that support while they are providing that 4 hours, the child doesn't have the infrastructure or instruction or contact with their classmates. And there's also not a hybrid model. A few states for non-traditional allow a hybrid model, like California stands out. A few years ago, they allowed for this child to be dually enrolled where their hospital program is, as well as their original school, so that they don't get disenrolled for missing. And maybe that parents waited 2 years to get into a particular spot. But also if it's intermittent and they're transitioning back, they can get provision of service in your school of origin. And then when they're in the location of where the hospital programming is or the intensive outpatient, they would get the provision from the school that's assigned to that area. So we wanted to see, okay, we saw that Arizona has a statute. We didn't think comparatively that it was as detailed or flexible for our students, but we wanted to see what the schools had in terms of their policies in Southern Arizona. So we looked at the 3 main counties, Pima, Cochise, and Santa Cruz, to see where they were. We contacted them. It was during the summer, so we were only able to reach 10 schools to find out exactly about how many they were serving and how they implemented the homebound policy. But also we looked at all district policy handbooks. One thing to keep in mind that even though we focus on homebound, Arizona does have another statute, which is possible for other states, that if you are not eligible for homebound or that you do not believe you'll miss more than 90 days, that there is a education for students with chronic illness, pupils with chronic illness. And for those kiddos, the only part of the statute in Arizona is that they have access to homework, so they don't lose credit. So that is on the next slide. One of the things is that statute, that was another intermediary one, but again, only thing in that statute is specific to homework availability, not instruction, not contact with the teachers. There were a few districts, as you can see, that talked about whether a teacher certification was required, whether the teacher needed to collaborate or coordinate, and how often it needed to be renewed. Those were district specific. And in that case, the schools, like for example, TUSD talked about different ways that instruction could be provided, and it was much more accessible. We didn't have to call and dig through. Their website does lay that out, and that's Tucson Unified School District. Other districts there had much more detailed plans and not only additional paperwork for the parents, but a discussion and outline of how the process works. Because when parents are here and going through that process, the more that they have to dig for this information, it's just draining. These parents are worrying about their child's safety, health, school. They want their child when they overcome what's going on, maybe to be as connected and not left behind. But on the other hand, they want their child to be well and alive. And so the more that schools can make this transparent and the more fluidity that can be worked out between a hospital and school. And so a few of these districts do have delivery methods and different things. And on the next aim that will be addressed is what's happening in Southern Arizona, as well as is our next steps for how we're looking into this.
So, just very briefly, just due to time, we did also do a case study on a hospital school located here in Southern Arizona. We also used publicly available information on this hospital school as well as a 45-minute Zoom interview. And we had a very thorough interview protocol as well as validity and reliability measures, such as member checking, team debriefing, and other techniques to make sure that we were reliable in our methods. The main outcome of this hospital school program in Arizona is it's a single full-time teacher, really, with 30 years of experience providing support for an entire pediatric population that includes oncology, hematology, eating disorders, dialysis, and so much more. This operates under the Child Life Specialist Department and is primarily funded through the Hospital Foundation itself and donors. This is not a billable service. It's provided free of charge to the patients and their siblings. One of the key challenges that we found in this interview is really struggling between balancing medical procedures with education. So a lot of instruction is interrupted. There is inconsistent school collaboration, so it's really difficult for our hospital school teacher to get in contact with the districts or the specific teachers that the child is working with in their primary school. There is variability in family engagement with education. Some parents really want the hospital school service, whereas other parents are a little bit more skeptical to it. So providing some psychoeducation about the benefits of some school support within a hospital setting is needed, as well as the need for specialized professional development. A lot of people don't know that a hospital school teacher exists. You can be a teacher in a hospital. And so there's really a lack of how to become a teacher in a hospital. How do you serve various pediatric chronic illnesses? And what kind of accommodations should you be aware of? And one of those key things is to be very informed about special education policy and how to support children who require IEP or 504 accommodations. So in turn, with this policy analysis, with our discovery of Arizona districts and how they're serving our students and the current hospital school program that's providing services to children in the hospital, we have some pretty lengthy but recommended positive recommendations for Arizona to grow in this policy. One of the biggest things is to reduce eligibility from 90 days. Like Dr. Perfect was saying, that's almost 3 months of possible missed instruction to around the average that we're seeing across other states. So those 10 to 15 days, expand those providers who can approve homebound, add timelines for decision making and implementation, increasing instruction to 8 to 10 hours, considering secondary students like high school, middle school, and having that variability between the grades, including transition support, ensuring that teachers are provided adequate training to provide homebound instruction or hospital school services, and really clarifying this and supporting intermittent services. So those students who will miss some days but can return on others. Curriculum requirements is another recommendation, is that Arizona should be ensuring that all of their students have access to supplies and materials, in addition to standardized documentation process. How are we documenting absences? How are we documenting how many students we're serving in Arizona? And last but not least, strengthening and broadening hospital school programming support. So not working in isolation, but homebound and hospital school programs should really be collaborating and working amongst each other to provide more support. So having a teacher liaison and outpatient services that provide instruction as well. These are some of the best practices from leading states that we wanted everyone to be aware of, and where we kind of pulled from our recommendations for Arizona specifically. So New York, like Dr. Perfect said, recently increased their hours to up to 15 hours a week. They really have those clear transition planning support. Illinois defines intermittent absences very, very clearly. You understand what it is. New Hampshire has a transition plan for their students and how to help them return to school once they're medically able. DC provides comprehensive appeal process in case the decision wasn't up to standard for parents, and multiple providers who can approve the service. Connecticut provides detailed curriculum continuity, whereas California allows partial return and dual enrollment. So you can be enrolled in homebound or a hospital school program as well as your primary school setting. Michigan and Wyoming was very clear on time until eligible. New Jersey and Minnesota were provided models for determination and implementation. So we can really see that a comprehensive model to accessible homebound instruction is possible. So moving forward, we really want policymakers to update their statutes, not renounce them. We want to reflect best practice that's grounded in evidence-based practices. School districts should develop standardized implementation procedures. Healthcare providers, we should really be improving coordination with their children in our districts to emphasize a family-centered approach. Our families should advocate for better services and know their rights. So really doing community psychoeducation that this type of service is available. And researchers should be continuing our policy effectiveness and monitoring that. In other words, our presentation really wanted to explain that every child deserves access to education regardless of their health status. Here is just an opportunity to participate in research, or if you know any students or parents who have hospital, school, or homebound experiences. This is a part of my dissertation, continuing the work, moving forward, understanding how homebound and hospital school experiences impact instruction and consultation. Participants can be refunded for their provided a gift card for their completion of the study. So just an opportunity to engage in research. Please feel free to share this with anyone that you feel could benefit. And here are our references. There was plenty, and you can find them in our paper. And now we would love to just, if we have time, answer any questions that you may have. Thank you so much.
Hi, Carl. Well, thank you so much for that, Michelle and Carl. That was such a wonderful overview of the learning opportunities for students with chronic health conditions. We'll hold questions until after Kathy's presentation. Just wanted to throw that out there. So if you do have any questions for Michelle and Carl, please put them in that Q&A chat button at the bottom, and we'll moderate those questions after Kathy's presentation. Really, this is such an important area that you guys are working in as a parent of a student. I found your white paper incredibly informative and valuable, and I encourage everyone to check it out on the MAP website. I put that link below. So thank you for your time today and really that excellent white paper that you provided for the MAP dashboard. So now I would like to ask Kathy to turn on her screen, and we'll welcome her. And we're going to play a short video before her presentation, but I think I'll read her bio here in advance of that video. So Kathy is a community health education advocate and nonprofit leader. She's based here in Tucson, Arizona. She has a master's in organizational leadership with a certificate in servant leadership from Gonzaga University and a bachelor of science in special education from the University of Arizona. She was selected as a 2024-2025 Arizona Lend Fellowship trainee in the University of Arizona's College of Medicine. Arizona Lend is a nationally recognized leadership training program in neurodevelopment disabilities and autism spectrum disorders, preparing interdisciplinary professionals to improve the health and well-being of children with developmental differences and their families. Kathy served as the leader of design and community healthcare at Home Court Advantage and is the co-founder of Team Lizzie Bell, whose mission is to address the gaps in services for families facing urgent, dire, or unexpected situations in the care of a medically fragile child. She is a proud Tiffany Circle member of the American Red Cross, one of just 1,400 women worldwide who champion the mission of this international humanitarian nonprofit. Kathy is deeply committed to preparing the next generation of leaders. She volunteers with the University of Arizona MAPS, Minority Association of Pre-Medical Students, supports students that earn to learn, and shares expertise on workforce readiness and leadership through Society for Human Resource Management webinars. Kathy's advocacy is grounded in her family's journey with pediatric healthcare and transplant medicine. She has been married to her college sweetheart, Mike Bell, for 44 years and is a proud mother and devoted grandmother. Outside of her professional and volunteer commitment, she enjoys dancing, singing in the rain, and cheering for her beloved University of Arizona Wildcats. Welcome, Kathy. We're really excited to have you. And we'll start the video now.
In 1994, we had to take care of Lizzie's rare, serious medical condition. Diamond-Blackfan anemia means that the red cell production in the marrow either does not produce any red cells, or the cells produced are too weak to survive, or they die quickly once they're out in the bloodstream. When you're sitting in the infusion room and your child is young, you've got to feed them meals. It's because you arrive early in the morning and you're there all day long. You're having to go down to the cafeteria, or you're having to bring things. I noticed that I was the only one bringing a tray back up, and I would go down to the bank machine and I would buy 3 or 4 hamburgers and 2 things of fries and, a couple of juices or whatever. And I would cut it up and I would say, okay, whoever wants to have some, let's all share. As a family, being in the hospital, Team Lizzie Bell really started by wanting to give other families lunch. Diamond-Blackfan anemia means that the individual needs frequent transfusions. We had raised so much awareness about blood donation that Lizzie was awarded an American Red Cross Hero Award. Her telling the story of her life inspired others to give blood. This evolved, we helped provide various items. These are now part of an entire mission.
Entering this closet and sorting through the toys, 25-year-old Lizzie Bell is taken back to her childhood when she was living in the hospital.
It was a saving grace when I was younger.
Lizzie was diagnosed with Diamond-Blackfan anemia disorder, meaning her bones didn't make red blood cells. She spent the first 19 years of her life living in the hospital getting blood transfusions, but it was these toys that kept her spirits up.
I love shopping, so it was kind of like, okay, if I can do this one thing, this one needle, then I can get this toy.
Throughout the years, Lizzie noticed there wasn't always a toy in the bank, so she wanted to change that. Through her organization, Team Lizzie Bell, toy banks in local hospitals get donations to keep the shelves stocked, and that includes the new closet inside Tucson Medical Center, Lizzie Lute's Toy Closet.
We want to make sure that any kid who gets a needle gets a toy, no matter what.
We've grown, and we at Team Lizzie Bell have designed a program called 94 and More. And it means that we have the ability to sponsor a family in that dire gap of need. And your help is what helps us continue to serve.
At Team Lizzie Bell lies a noble mission to uplift medically fragile children and their families. We've joined Tucson hospitals and identified 7 pediatric groups reliant on life-saving blood transfusions. Your help matters. Donate blood to our local pediatric patients, a toy to help kids get through the tough days, and money to help offset the costs these families endure. Let's make a difference. One donation, one toy, one act of kindness at a time. Visit teamlizziebell.org to contribute and bring joy to these incredible children.
Welcome, Kathy. It's amazing work that you're doing for our community. So I'll turn things over to you now.
Yeah, it's the opportunity to talk about this really touched me deeply, obviously. I got to know Kato a little bit in the Arizona LEND program, and when we first met Dr. Perfect, we thought her name was perfect because of the work she was doing for the hospital school research. And so the video always, and this, going back over this white paper, I was mentioning to the team that it just brought back so many memories of the challenges. And in looking at the challenges, the evolution of what Dr. Perfect and Elgato is doing, and how much this kind of information is needed in order to create the catalysts and the anchors and the people and the money and the time in order to create positive change that matter for these children in their journey in wellness, and the families, and especially the siblings. That's a whole group of people that have to be looked at when a child becomes chronically ill. And over the years, Lizzie's 31 now, so over the years, we've met so many families. And I think part of our journey, just in helping people get lunch, we realized how much more all of these individuals need. So in March of 2026, our organization will be 23 years old, with Lizzie being 31, 32 in May. So she graduated from college and got her degree, but yeah, it was quite a bit of a journey. And I think you can see from the video, when she was an infant, she was 7 weeks old. So all of those early childhood milestones that you're looking to help, foster in your little one, you have to realize that all you're doing is saving their life. You're working every day to determine this rare condition, like what is it? And then where do we get help, and how do we do anything? Because sometimes the simplest things aren't as normal processes or pathways for, like you did with your other kids. So we have 4 children: John, Amy, Lizzie was third, and then Alicia is our last child. And in the middle of all that, we actually adopted a teen mom. She was she gave birth on the day she was supposed to start 8th grade. So we had quite a bit going on back then. One person always leaves whatever they're doing in order to go bedside. And when you're in the throes of all the things that mothers do, or the father's doing, or the primary caregiver's doing, all of a sudden you're having to maneuver so many aspects of the care. You're having to deal with so many dimensions of healthcare that you didn't know they could put needles in certain places and spaces. You had no idea the volume of people they're going to introduce you to, give you a menu of services to go figure out, find, and then work at getting there to implement whatever that next process is. Anytime you have a good day, you're trying to just get together what it is that you left behind, especially when it came to the siblings. And everything is not normal anymore, but you don't realize that. You somehow keep thinking that you're going to get to a place where it'll just all be about the dishes and the laundry and, school lunches or whatever. So while you're pioneering this new part of your life, you don't realize that when you get a service from the hospital, or you get a service from your social workers at the clinics, you don't realize that these are also manifestations of people pioneering something too. So the hospital school processes, family-centered care, all of these things were all developing at the same time we were moving through the system. And we didn't know that. So we don't know that we're part of a movement. We don't realize that these are new abilities that everybody's trying to make sure they happen for the families. And the magnitude and the diversity of all these different rare syndromes or diseases that can hit a child and that impact the family. All of these are something you're looking at that one care provider or that one social worker. You're looking at maybe 2 or 3 people. And now there's this thing called child life. And so you're so thrilled with child life that you're trying to figure out, I'm gonna grab a Kleenex here. You're trying to figure out what it is that they do. And you grab on, you hang on to every single bit of what it is that's happening. Another dimension of this child's life is the fact that you're having to talk about things that you never talked about. I mean, if you had a family pet and the pet died, then you could talk about, what happened with the family dog. But when you arrive at the hospital and you find out that one of Lizzie's friends has passed away, and the child life person says, we're going to talk with Lizzie today because she's not going to see her friend anymore. And you listen to how they describe grief and death and what has happened to her friend. And I remember just looking at this person and saying, how did you learn how to do that? And they talked about, I had a class in college. You realize that we're all hanging on thin threads. And how are we going to do this? So I am thankful that there is this roadmap that's gotten so much bigger and deeper. And so for us, there were a couple of big milestones that helped to make a difference for Lizzie. Number one is that our physician was part of a National Center for Excellence. This isn't typical or always true for families. We had a physician who was connected, who connected us. We found ways to travel to these different centers of excellence or to a machine that they could do different tests on Lizzie so that we could get an adequate analysis of what was happening in her body, because transfuse dependent kids develop antibodies so they begin rejecting the blood. They develop liver iron overloads. They develop the medicine that keeps Lizzie alive was ototoxic, so hearing, visual, teeth, definitely teeth were challenged. You have things where if she's a low hemoglobin, so you're asking her to hold a pencil in class, or you're asking her to concentrate on something else. The brain can't register process 1 to process 2. She's still trying to figure out process 1, and her fingers don't necessarily have a lot of blood in them. So these are the things that you don't realize it at the time because she's laughing and she's having a good time at school. But that was part of the problem, is that we would get told, Lizzie sure has a lot of fun at school. She doesn't know that when she's in school, she's got to do schoolwork, because she always thinks that she's at the hospital having fun. And I was like, you have no idea what is happening at the hospital, because a lot of it is not fun. So you're, as a parent, you're maneuvering a lot of different aspects of this. A couple saving graces for us were that both of Mike and I wanted her to be educated and keep up with her schoolwork. So making a priority to meet with the hospital, the school nurse and the school principal. And I set up the in-service. I brought in the people that could talk about Lizzie's condition. I brought in what it was that had to be there for the school to be able to help her, so that we were on the same page until there would be something new that would change. Another aspect of those in-services were better understanding of what the school could provide. So whether she was, because Lizzie was in a couple different places, in a faith-based school, in a charter school, she was in a homebound program, she was in the hospital school, she was in Primavera. Once she graduated out of high school, she had only taken a small portion of classes in high school because that's all she could tolerate before her transplant, her marrow transplant. So she never really completed the high school program and had to do high school all over again after she was done with her marrow transplant. And then she went on to the University of Arizona and graduated in the University of Arizona. So she's 31, and that's 25 years of really forging through pathways and all different kinds of recipes that we were all trying together and making things stick. We also had a couple of educators in the family. We call them the aunties. And a lot of times Lizzie would be in the hospital for the entire weekend. So she would check in on Friday night, and then she wouldn't check out till late Sunday night. And so the aunties would go over there, and they would help her take a look at whatever the education material was that she had been assigned during the week. And they just helped her describe it and helped her get through it. And with the computers today, it was easier to turn in things or to type or whatever. Some things that were unpredictable that became very pivotal were things like the University of Arizona had the psychology club, and they came to the hospital and they made scrapbooks. And so the scrapbook was a way to talk about their life. And because they were doing the scrapbook project, they were able to write and process and take a look at things that were relevant in their world, but it was also an academic exercise in and of itself. There was another college program that offered the kids a way to make their own song about their life. There was, you have nonprofits here in Tucson, so we did a lot with Beads of Courage. And that work that Jean Baruch has done in Dr. Jean Baruch has done in Beads of Courage really helped solidify the medical journey for Elizabeth and gave us the opportunity to express the medical side of what Elizabeth lived through, which gave her the freedom then to be able to move on, because that's kind of the way things go in Beads of Courage. You hold those beads and you know you've lived through something, and then you can put the beads down because you want to move on. You've got to move on. We traveled. There was a medical camp, a free medical camp in Maine. And we went there several times. At the age of 5, Lizzie learned to put the needle in her stomach. You saw that in the video. So if you wrote about that, if you talked about that, if you showed others what you had to do, these are all educational processes that gave Lizzie a whole different language. She learned her own protocols and could say them to the physicians and wrote them up. Wrote the physicians, not the attendings, but the residents up if they didn't work with her on her own protocols. So she was a little feisty little girl there. There were other things that, because of her medical lifestyle, she learned to speak doctor. And that's a big, huge part of these chronically ill children, is being able to help themselves as they move on in the transition of care. So by the time Elizabeth went to Minnesota for her marrow transplant, she was so rare that we couldn't stay here in Tucson, and we were gone almost a year. We were able to meet a lot of other families and really learn a lot about their school processes and what was happening within those medical institutions and all the community partners. So I think one thing that became excruciatingly clear on this is that I really feel like by the time we wait for the state government or the federal government to really put it out there for us and with us and partner well, I wanted to find that model that talked about what else is there as we go down that one road. And looking at the family-centered care model that came out of the United Kingdom before it ever even got here to the United States. That was something that really got solidified more, I think, around 2003. Lizzie was born in 1994. So we were on a trip to this medical camp, and Lizzie's portacathode needle had a traumatic situation. And so at a layover in Minnesota, we had to get off the plane and we had to get over to the emergency room at the hospital. And so family-centered care was really relatively new. And we got into the room, and when the nurse came in, she stopped right at the doorway and she said, "Lizzie, my name is, and I just want to let you know that you're been with this so long that I'll bet you know what to do with that needle. And so I want to have you tell me how we're going to do this. And so she said, I'm going to bring this tray in and you tell me which product you like and how you want to work with this. And Lizzie gave her the whole instruction, and together they had to do the painful part and redo everything. But her definition and how this hospital had been trained in family centered care was different than my hospital. And we got to see this model, this evolution, because people within the working boots on the ground took it upon themselves and they made these things happen. And I kind of feel like that's what's going to happen with the hospital schools. I think it's going to be us parents. I think it's going to be the clinicians and the districts, school districts and school boards. For family-centered care, a lot of it really got solidified because I believe it was the Surgeon General, the department, was the Academy of Pediatrics, and the Health and Maternal Child and Health Bureau that really helped to solidify what has become really a standard of practice of allowing parents to be partners in their child's care, and how we see that today. So I think that part of my role, and especially with all of this, I think part of my role is empowering the families and the parents and the people we work with in our nonprofit to take it upon themselves. We're gonna notify you when there is a patient and their school needs to know that they've been in the hospital. That's just ridiculous that 90 days has to wait. One school counselor that I was talking to this past weekend, one of the aunties, she's retired now, but talked about a little child that was just kind of resting his head on his desk. And by the time she had a chance to visit with him, found out that he had not only watched one family member commit suicide, but upon dealing with that, his sibling also committed suicide. These are not things that teacher should find out in the classroom. This was information that somebody knew somewhere that wasn't conveyed. That's the kind of thing I'm talking about. How is it that we don't have these communication systems within our school counselors, our school nurses, people now, so that we can convey what we know in order to start these processes on our own? That is something we can do without having to have a policy or this can be something we anchor in together and create within our districts and create within the state of Arizona. We should not be last in this. There's no way we should be last in this. And the hub of the wheel for Banner is here in Tucson, is here in Phoenix. And so this is the kind of thing that the leadership of this organization and all of our families really can stand firm on and create that as just a way of life here and not have to be be waiting for them to tell us that, because we're just going to do this, just like in family-centered care. We're going to do this, and this is how we're going to do it. And these are who our partners are. This is how we're moving forward. And I know that as far as my part in what we do in our nonprofit can be much more proactive than what we've been in the past. I'm sure if there's questions, I'm just trying to think of anything else, but I think one last thing too is that we ask these kids to do a lot, and we've never really incorporated a registered dietitian into the mix. Elizabeth's sister Alicia is in Chicago now as a registered dietitian, and we need to feed the cells. Then we need to think about what nutritionally is happening with these kiddos, and on some level somewhere this also needs to be part of the program so that we can have expectations for what they're living through because we're feeding them. So thank you.
Yeah, Kathy, thank you so much for joining us today. We're really happy that you're able to provide your perspective as a mom who's gone through this, but also as a community leader working on this really important topic. And we're hoping you can provide the web address in the chat below to Team Lizzie Bell, so those who are interested can donate to help support this really important work that you're doing in our community. And so I'm going to ask Caro and Michelle to also turn on their videos now at this time. And we're going to go through some questions that have come in during the presentations. And I think we'll start with one that might be a little challenging and difficult. And that is with what's going on with the U.S. Department of Education. How do you feel that is this going to have an impact on in this area for students with chronic health conditions? And whoever, just jump in.
Yeah, I think I'm able to answer it from a larger perspective, and then I think Caro has an update related to some people she's spoken with as part of her study. But I definitely think so in the sense that, one of our ideas was to have a little more thread or continuity at the federal level, to have a little more stronghold there, that even if states have their autonomy to implement or devise a statute, but that there's some expectation or requirement or mandate that there is more, that there is something. And I believe at the current state of things and philosophy of the way education should be managed is that at the federal level that will not occur at the current moment. Again, that's a philosophy. It doesn't mean that it's the only way, but I believe if the expectation then is that states are responsible for the education, then why are 11 states not even mentioning it and silent? And why in some of the policies is it almost insulting and harmful to be there as opposed to not? And why did one of the states, I don't want to name it in case I'm wrong, repeal their entire law? Wasn't huge, but why, like less than a year ago? And then the other thing is for these states, some of them last updated were within the year of when we were coded, but some of them had been developed in the 1960s and 70s and not even revisited. So I think one of the things I contrast also is I will use Wisconsin again. They have a document of what is required by the district and it's been updated a little bit over each time they have a new attorney general or superintendent, I should say. But it basically says, is there a requirement for schools to provide services for students who are hospitalized? And it says no, right in the thing. And then there is a parallel document where it says about where is there a requirement for provision of education for those who are in juvenile detention, and it says yes. And it says because they require free appropriate education, and it gave several court cases that came about that required that. And so I think in some cases there has been some cases, that wasn't part of this study, but there have been some cases where a child's parent sued the district saying you're not giving them education when they can't do it during the day here, and it ruled in the parents' favor at one point. I didn't follow the whole case through, but I think unfortunately until there is some of these policy changes, as Kathy mentioned, it's not necessarily going to happen at the more grand level. But I think there could be some more, I don't want to say grassroots, but there could be some more advocacy and organizations and funding around it so that people can't say we don't have the funding and services for these kids. And I know Caro did have a quick update, at least she mentioned it yesterday, related to an impact on at least how it's trickling down.
No, that's a great question, because those are the times that are currently impacting us now, and we're beginning to see it in particularly hospital school programs, because this hospital school programs are not a billable service. They do not generate any type of revenue for the hospital school. These are the type of programs that are typically cut first. So I've with some of the hospital schools teachers that I've talked to across the country, unfortunately, their hospital schools have already been cut. So that means that the population that they would serve is no longer being served due to funding being diminished in hospital schools primarily. As of right now, I don't know what this would mean primarily for homebound instruction, since those are two different types of interventions for these children. But I'm suspecting that because it's up to the state at this point, hopefully it'll be able to remain. And yeah, it's pretty sad to see that, we estimate only 110 hospital schools currently in the United States. So with that diminishing instead of increasing, that is pretty worrisome for us.
I did want to add one more thing, actually. So, like in the state of New York, they're part of the hospital. We say the word program a lot intentionally because it's a program that supports the education of students. They do often hire that educator that has certification, but there are some states that actually it's a hospital school. And so like in New York, there's a principal or a head of the 5 boroughs of a hospital school, like program. And so some of the state departments of education do oversee and have regulatory oversight of hospital schools as opposed to programs. But that's why we use programs specifically, because it is not, the state is not required to accept the credit that goes to them. They're not required, although many states have required contracts like Florida and different things, but there are some that do have the actual hospital as a location for the instruction set up.
Thank you, guys. We also have another question. I think it kind of, I'm interested in your perspective, Kathy, over your child's lifetime, and then also Michelle and Carl, what you've seen in the research is, in what ways has the care for young children with chronic health conditions improved or gotten worse over the last 30 years? And then I kind of want to add on to that and ask, what you've seen in the research over the last, couple decades is, are there any states where you really feel that other states can look to kind of for best practices in providing care to children with chronic health conditions?
So for myself and for our journey, whether it was California, Chicago, New York, up in Maine for the medical camp, and physicians were flown in from all over the world, actually, for the week that we would be at these camps. I think when we were in Minnesota, I saw the most efficient. And I had to learn that whatever was happening in healthcare bedside, there was a lot of that I could not change. I could change that if she was going to be knocked out, we're doing everything when she's knocked out. And so you've got to figure out how you're going to schedule this. But, and that way it was as pain-free as I could create it to be for her. In Minnesota, there was a lot of nets under the families so that they knew when our flight was in, they knew the Ronald McDonald rooms, just so many details. The parking garage is under construction, so you'll need to do this, you'll need to do that. By the time you actually got into bedside where the sad stuff happens, you were a lot calmer because there were a lot of people helping to manage your path. And didn't necessarily see that when we went to LA for one of the machines. It was hell trying to figure out where to go. There wasn't, you're on your own. Here's the paper they sent you, and so I don't know that it's that way anymore, but my point is that pain management, I think, is another thing that in some places it's really good, and in other places it was hellish to try and figure out how we were going to be a little bit nicer, kinder when we could have, because we had seen it. So I think those are in the healthcare. Has it gotten better? It depends on what it is that we're doing for the child.
Yeah, Michelle or Cara, does the research support what you find, what Kathy experienced personally with Minnesota?
So I think that was for healthcare. It doesn't stand out per se. Minnesota and Cara, is that one of the ones that was coded? She can check that pretty quickly. I do know that, I would say healthcare has gotten better in the sense that more kids are surviving and that they're advancing care and treatments. What I don't know is that now are they thriving? And, in the sense of that now that maybe the laws that were there made sense and now they don't because more kids are living, but they still have treatments, they still have follow-up care, they still have those other components. For example, I don't know, again, implementation wise, but as I mentioned, Florida, whoever is going to deliver the statute basically says, or the regulation, whoever is going to deliver the instruction, whether it's going to be the school of origin or a hospital school program, they have to have a contract and they have to lay that stuff out and discuss it, and stuff. So I don't, again, I don't know in practice. I also know that there was I saw one of the other questions about the research of do these services even help other than maybe make the families feel better. Very little research on it. There are some qualitative studies, which is also following Caro's work, but a lot of it is in isolation, maybe usually about one hospital school program as opposed to the system or the way it's set up. So I think there was one, again, it was out of Florida within the last couple of years, and they did find that there was less withdrawal, and there was, particularly in the maths and sciences, those that were homebound, had more struggle. So the question is it enough? But that if they were enrolled in 5 or more classes, they were more likely to complete. So whereas we think that maybe we need to give them less, if they had a full infrastructure, even if it was modified or adapted, that they were more likely to complete it because they felt fully integrated. And then also, again, the withdrawal of like, when do we lose them in the beginning of the course because it's so hard to catch up? And how does that work? And that was like a statewide database that allowed for the comparison between grades and enrollment of those who were online or homebound to those who were not. And so to have that, even that statewide data collection, I don't know if other states have that. And I don't know if even if they have the data, if it's sitting somewhere dusty or if that's another area of, I don't know what Arizona has because there's no requirement to collect that data. So, but it made me, it was an excellent study in the sense of one of the only ones that have looked at those who are homebound at a more like statewide level.
And so based on what you discussed earlier, you think that it would be helpful to have some sort of federal guidelines for the states to follow in regards to how to help students with chronic health conditions?
I don't know, Caro, if you have your 2 cents there, because I know that's a big passion of yours. But yeah, absolutely. I think, even if it's like a dear colleague letter, like they do for how to implement things, in the sense, absolutely. I think if there's some guidelines related to that and the continuity, I think more states would consider it. I think it would be more received, obviously, if there was some flexibility. But again, some states, even just to have, I don't know, because it's not on people's radar. Again, if a politician in Arizona even knows that it's
Right.
like what's behind. So I think there needs to be some conversations to see if there's any traction in different states. If there's, Tennessee did have a big advocacy movement and they updated their law. And I know the people in that group, they published it like what they did get and what they didn't get of what they wanted, but they got like some of it, and it may not be the first time, but at least they got an update.
Right. So it sounds like just building awareness around this is vital.
Yes, definitely. Huge.
Yeah, people don't realize that this is so incredibly important. And a lot of these fragile kids, I think, like Lizzie had just such massive headaches. So you would look at her in class, never realizing they learn to not say much because they're always dealing with something. So by the time we could address it, she was hospitalized because her face froze from the massive headache and because she just didn't say anything. They learn to do something else so that they don't have to keep bothering you with their health. But I think Caro definitely has something to say about the federal.
Yeah, you guys are just providing amazing answers, and I think, with at least I think a federal guideline would be like the bare minimum. There should just be a universal policy, but every state's different, and their outlook on curriculum is different. So maybe leaving it to the states with a federal guideline would be the best option as of right now. And we're in a day of age where technology is just playing such a huge role, and these kids are already so socially isolated with majority of their social interaction is with adults, and throwing them online honestly isn't solution. I think it's a temporary band-aid, and these hospital schools and homebound instruction support allows for that social interaction. It allows for parents to not wear the educator role because they're already feeling so many. And it allows for teachers who already have 20 to 30 students in their classroom not have to worry about that kiddo that unfortunately is in the hospital. So I feel like it's an ecological model that serves every person in the system, whether that's political educational, medical, family. It's supports the entire team. And I think another component that we weren't able to touch, which I'm seeing in the literature, is these rural hospitals. You know, they already are so limited on their resources and funding. So when we continue to cut, these rural families are having to come to bigger cities like Tucson or Phoenix to receive these services. So also locating support where it's
Mm.
needed in those rural areas as well. And yeah, I think just starting in the community, that's where I just presented at the Arcos Fair with Kathy, and a lot of the families who came to my table didn't know this was out there. So it's like, how can you change something that you didn't know was there? So I think we just need to start at the bottom, and this is a start with this webinar of showing people this is there and where we're starting, and then we'll be able to make those bigger changes.
Right. Yeah, I agree. Just creating awareness around it. Like I was not aware of these issues, right? As a parent of a child, and so. But thank you for the work you guys are doing on this. And I want to ask something that you touched on, Kathy, a little bit, and that's like Lizzie attending different types of schools. And is there any difference between the public, the charter, the private schools in terms of how students can access care opportunities?
Yes. And it will depend on where the child lives as well. Just knowing from the Diamond Black-Fat Anemia group, we've got a large group of people that are across the United States, so this is a topic. But when our first two kids were in faith-based schools, and so if you had access to somebody who could work with a unique situation, special education, that kind of thing, then that person was available to the school, but it wasn't necessarily a hired person constantly working on any kind of major programming or component to the masses there at all. Then we moved into a charter school, and the charter school was small enough. The superintendent, everybody was on it immediately. And our younger daughter, Alicia, was reading within 2 weeks as a second grader, which was really shocking. But Lizzie got sick in her 8th grade year, left school, did not come back to school until her sophomore year. And so working with the different, whether we were in the school district, just within our area, or the charter school, or some kind of a home-based program, the charter school really was probably the most helpful. They got us a nurse that came to the school to insert her needle. She had to be on pump 12 hours a day. So, I mean, getting that needle done and just doing so many things, they were on it all the time with us until she was so sick that she had to leave school. But it all depends upon what the resources are. It all depends on how far somebody has to travel in order to get to that one kid. You know, so you're trying to figure out how many other kids are in the area, but you've got, one professional trying to get to one child, and that's not good either. So, but the stuff we needed had to be hands-on. So it wasn't like we could do telemedicine to insert the needles and get her pumps on. So, yeah, there's always going to be a big difference in that. From part of my leadership project that I did for Arizona Lend, I traveled to Bisbee and down in Benson to kind of look at the rural health settings and just what was the magnitude of programs offered and how well were they being received, no matter what the program was. And parents have their own challenges. A lot of times I know that there's that shame involved. We don't talk a lot about the fact that we're just exhausted and we just can't accomplish all the things that need to happen. And it's just one more thing that is coming at me and I'm failing. And so the shame of getting over to that public health department or getting over to that program. And so I asked at these different locations, where do you see the most success? If there was a program for sports, then you saw the NANA, you saw family members get the child to the location to get the physical, to do whatever they needed to do for sports. So those were the moments where somebody has to be there to say, oh, and by the way, if there's anybody that you know that needs to be part of a hospital school program, this is what it means, and this is how we help, and this is how we hold your hand so that we can push the button, so that we can activate. That was the other half of it. I hear what you're saying. I get it that I'm supposed to make a phone call, but when I dial the number, I don't know what to say. I don't know what I'm asking for. This is so big that they've missed this much school. You got to tell me again. It's almost like you've got to write out a script or do a flow chart with it. And so, it's like, I get it. It's English or it's in Spanish. I can't do it. And I don't know how to tell you that I need that help in some of the simplest functions. So in my leadership project with Arizona LEN, that was one of the things, taking a look at just what were the complexities of the rural families versus those of us who can ask a neighbor that has gone through something because they're in our school district or whatever. It's just, it's compelling, but yes, there's a difference.
Right. And I think, we talked about it prior to today's NAP talk, but parents are so overwhelmed, right? They're thinking about the health of their child and their child's well-being, physical well-being, and then the financial aspect of that school is just like the secondary thing to worry about, right? Or not even secondary, it's like down the list, 4, 5, 5th thing to worry about. And so the schools being able to help and provide those resources for the parents without them having to worry about that on top of everything else that they're worrying about.
I think it's interesting. Dr. Perfect is an aspect of diabetes, and one of the moms I was talking to, her son has lots of situations with his diabetic condition, and both of us compared on that. And any given day, at any moment, we knew exactly what road we'd take, no matter where we were to get to that hospital. We would know who to call to find out who was on call. We would know what door we were going through and how we were going to make sure that we were going to get that child's care as fast as we could. That kind of urgency doesn't even leave you. You're so connected to the process because you've had to do so much to save this child's life. And she was in diabetic, the child with the diabetes, and I was in with Lizzie and her marrow condition, but yet as mothers, we were both fierce about how we would do what we need to do to get that child help. Now take me in and go to school. I'm still thinking, okay, Lizzie's at school. What road am I taking to get to the hospital? What time of day it is? Okay, so I'll know this, that, and the other. I mean, I hear what you're saying, Dr. Perfect. I hear what you're saying, Gato. I can hear it. But right now, I just got to make sure that I know 3 o'clock traffic can get, but by 5 o'clock, that road's going to be bad. So you're going to have to do this. You're going to have to do that. You'll have to go here. That's where our brain is because of our children. And she wasn't, of course, it's life-threatening. It's just different. But as moms, boom, we connected.
Yeah. I think one of the other things, so one of the model school hospital school programs, I mean, obviously I'm not there, so I don't actually know, is like the University of North Carolina. It's in Chapel Hill, and they have a feature where they said it just started with one, and this was 50 or 55 years ago. We started with one in almost a decade ago now, and Tucson, and now they have 16 staff, including a halftime media specialist. They have a media specialist room, and a media center, and they also say sometimes it's not about the kids coming. They cannot leave their bed, so that's where the bedside, but sometimes it can be televised, and they have these physical spaces, and they have that continuity, in their, now they serve 2,000 students. I don't know the ratio for Tucson in general who are hospitalized or intensive outpatient. I think that's another thing. Some schools allow for that intensive outpatient, if you have a lot of treatments, and so you would leave school, come back to school. Instead, you're at the hospital already and getting school. You have your treatment, and then you still get some more school. I think that even though it's uncomfortable and definitely boring and stuff, those kids on dialysis, they're sitting there and they're a captive audience, and they're playing on their, devices sometimes. And I know Phoenix Children's does have a devoted teacher because they're funded privately for those on dialysis to provide instruction. And so, I think again, it depends on the ratio and the numbers, but there are some in Arizona even that do that, but to have I can't even imagine 16 staff for a school program and in one place, but it does just start with one. So now there's a program and there's a system. So how can we keep that growing?
Field trip. Field trip,
exactly.
Well, yeah, Cara, do you want to add anything or?
No, it's amazing to hear Kathy's side and to continue the work. And I think yeah, it's I'm just my heart is full just because we don't get to talk about it often. So it's thank you for the opportunity, honestly.
Yeah, no, I think it's been a great Q&A session, just providing more perspective on the challenges of these families and students with chronic health conditions. I will thank all of you for joining us today. And as we mentioned before, we will have this posted on the MAP website and we'll share it with the MAP community and with our partners. And we encourage you to share it with those that you find interesting. So just they have the opportunity to learn more and to create more awareness around this really important topic. So that concludes our MAP talk today. And again, thank you all and have a wonderful afternoon.
We appreciate your guys' time. Thank you so much. Thank you
Thank
for
you.
having.